the most important of this retinal arterial occlusion. It's representing the second most prevalent retinopathy behind diabetic retinopathy, and at the same time it's a common cause of severe visual loss or impairment, and can affect all ages group, and strongly associated with systemic disease and prominent morbidity and mortality. What are the known types of central retinal or the retinal arterial occlusions? We have the first and the very mild form is the cotton wool spot, followed by major central retinal artery occlusion or branch FNO, cilioretinal artery or ophthalmic artery occlusion, and carotid. So all this is considered to be causes of retinal arterial occlusion. So we have more than, but mostly the most common types are either central retinal artery or branch retinal artery occlusions. If you look for the blood supply for the globe, we have the main trunk is the internal carotid artery, and that give branch for I think so this is if you look for the main, we have two, the central retinal artery, which is getting out of the optic nerve, and we have the short ciliary arteries, which are branches of the ophthalmic artery as a branch of internal carotid artery. And all this is an important to the site where the obstruction usually happen or the pathology. And apart from that, we have the cilioretinal artery, which is really is not coming from the ophthalmic or from the central retinal artery, which is coming from the choroidal circulations. This is the definitions of each of one of them, and I'm sure that you are aware about it from your basic science, vascular supply of the globe. So we'll not give 2 times for that, as we have a lot of things. When we are looking for the causes of retinal arterial occlusive diseases, we have to make it in order so that we can recognize where we have to go and how to work the patient. We have causes that mainly focus on the luminal obstructions, or may that associated with the laminal narrowing, including the atherosclerosis, vasospasm, vasculite, and external compression, or retinal hypoperfusion, and this could be secondary to systemic hypotension or ocular hypertension or blood dyscrasia. We use usually the varicose load that can help us. So we have the arterial site here, and we have causes that coming from outside the lumen or might be in the walls like atherosclerosis or inflammations, and then we have the causes that could be inside the blood vessels, and this could be related to emboli or excessive white cells or polycythemia. If you look for the causes, we can make it more simpler in that main systemic disease that associated with arterial occlusion, and you see how many of these are available here, or emboli related, or clotting tendency, or vessel blood wall inflammation. To make it more simpler, we have an endothelial damage or endothelial damage secondary to endothelial dysfunction or endothelial damage itself, or we have the hypercoagulability status, including hereditary or acquired, and each one of them having its own specialized causes. Or we have to think about stasis, and then we have to think about the general causes like immobility or polycythemia. So this is in general where you have to focus your thoughts. If you are going other way and put it in table like this, we have the systemic disease, the systemic cardiovascular disease, we have the coagulopathies, systemic vasculitis, oncological causes, infectious causes, trauma, and ocular condition, and other causes. So put this in your mind, summarize it, and then you can start to work your patient based on the situations and the age of the patient and the possible systemic cause. So what's happened usually when you have arterial occlusions? We started to have diminution of arterial blood supply, that followed by ischemia, then followed by necrosis, and then atrophy and degenerations. And this is, by the end, it's lead to replacement with fibrosis. So this is the general sequences of any arterial occlusions. Clinically, the signs of the occlusion might be focal occlusion of small retinal arteries, like the cotton wool spots, or global ischemia from ophthalmic artery occlusion or central retinal artery occlusions. Cotton wall spots representing the smallest examples of just mild arterial obstruction, and as you see here, these patients might be at risk of major causes of this central artery. What are they? Are representing transit, small, whitish opacities with feathering edges located with the superficial retina, and represent, as we said, microinfarction, obstruction of the small retinal arterioles and resultant ischemia, and may cause symptoms of a small scotoma of acute inset, and usually tend to disappear in weeks, from 5 to 7 weeks. So it's usually just transit and representing an important signs of arterial obstructions. The pathophysiology of cotton wall spots, usually from retinal ischemia and focal hypoxia associated with disruptions of normal retinal cellular metabolism, transport, and accumulation of cellular debris. And exoplasmic debris, thought the one that lead to the color and shape of the cotton wall spot. In the light microscopy, it is having characteristic cystoid bodies, as we see here, and cellular appearing bodies with the pseudonucleus within the nerve fiber layer. The cystoid bodies composed largely of degenerated mitochondria and intracellular debris. So this is the pathophysiology in specific of cotton wall spots. In fluorescein angiography, usually they have small areas of hypoperfusion, and at the edge of the normal and abnormal nerve fiber layers, we have some sort of irregularity and distinguished edge because of remodeling, or what we call it, starting to have an early telangiectatic blood vessel to having the site to supply the deficient area. This is the examples. If you see this patient in the red free, we have large cotton wall spot. When you do fluorescein angiography, just only you see that the hypoperfusion at that area as hypofluorescent corresponding to. Causes of the cotton wall spot, usually an indication of systemic vascular disease in general, either ocular or systemic, and general systemic evaluation having the ability to discover 95% of patients presenting with cotton wall spot. And the most common causes are undiscovered diabetic retinopathy in 20% of the patients, and systemic arterial hypertension in 20% of the patient. And in the nowadays, we have the acquired immune deficiency syndromes as one of the causes of cotton wall spot. And this is important. Single cotton wall spot is really deserved to have full investigation of any patient without systemic disease, so that you can preserve the life of such patient with just only looking for the possible etiology of. So don't take it lightly, and you have dig in the in your history and examination to find the cause of any cotton wall spot. Second, types of central retinal or retinal arterial occlusion is the central retinal artery occlusion, and this is one of the things that representing true ophthalmic emergency. It is showing that on 0.85% of 100 per year and 1.5 of 10-year cumulative incidence, and represent 57% of acute retinal artery occlusion. If you look all the types, we say that we have central, we have branch, we have cilioretinal artery, we have the cotton wall, and we have ophthalmic, and we have internal carotid artery obstruction. The central retinal artery occlusion is representing 57% of these types of occlusion, and might be bilateral involvement in 1 to 2% of the patients. Male are more than female, and the mean age usually between 60 and 65 years of age, and more than 90% over age of 40. And the etiology of occlusion changes depending on the age of the presentations. So you might have young patient in his 30 or 40 with retinal artery occlusion, and that's really needs to have their own types of etiology, and we have certain types of investigation that directed to this patient, especially when they don't have any systemic associations. In the case of acute obstruction, what will happen? Usually the inner retinal layer getting an edematous and Prognosis of the ganglion cells layer, and this is lead to what we called it the ground glass appearance, and in the same times we have and what we called it cherry red spot because of the back or outer retinal layer of the retina, usually supplied by blood from the choriocapillaris and choroids, and is still intact at this area with thinning of transparent retina. Usually we have the cherry red spots. The opacity is most dense in the posterior pole, as we mentioned earlier, because of the choroidal blood supply. And the foveal cherry red spot, usually the intact retinal pigment epithelium and choroid underlying the fovea, with fovea retina is supplied by the choroid, is not supplied by the outer retinal or inner retinal layers. So usually we have vascular foveal zone. In the animal studies, we have the ability to restorations of blood flow within 90 to 100 minutes leads to no retinal injuries. But if it's getting more longer, then the damage could be and maybe irreversible. The occlusion persisting more than 140 minutes lead to massive irreversible damage. And there is controversy that exists regarding the optimal window of treatment in the human being. The conservative approach involves treatment up to 24 hours, which is acceptable. But anything beyond that, mostly we ended by the permanent damage, and then whatever you do, it might not be help your patient, just exposing the patient to unnecessary workup or maneuvers. The symptoms, usually acute, persistent, painless visual loss. And in 15% of the patient might be presented with good visual acuity because of the intact cilioretinal artery. History, as we mentioned, starting with amaurosis foci, which is represent transit loss of vision lasting seconds to minutes. The temporal arteritis in the elderly patient should be suspected, and in this patient, usually we are asking about couple of symptoms related to giant cell arteritis. Medical problems that could predispose emboli formation, like cardiac problems or recent surgery, is important to be looked when you are dealing with the patient with central retinal artery. Prolonged direct pressure to the globe, like what we have in surgery before the cataract. We have hyaline palon that may be comprised for a long time, which is not be sometimes very well placed, might lead to such, or patient that having direct trauma with high pressure might lead to central retinal artery occlusion. And as we mentioned, drug history in this patient, it might be a risk for central retinal artery occlusion. In the examinations, we have to determine the degree of vision loss, to start with the visual acuity, either usually central retinal artery from light perception to hand motion, or even less than 2300. Check for afferent pupillary defects, perform an optic nerve examination to look at the signs of temporal arteritis, like what we say that an afferent pupillary defect, pale, swollen optic nerve with splinter hemorrhage over or surrounding the disc. During the examination, we might have a segmental arterial blood flow, as we called it box carrying, or we might have that to recognize the cherry red spot in these patients, attenuation of arterial blood vessels, and then emboli could be seen in 20% of these patients with central retinal artery. Other things that can look for this, if the patient's coming 1 week or 2 weeks, you might not find all the typical signs that you see it in the acute case of central retinal artery occlusions. This is another patient who's presented actually with acute loss of vision, and see how much of the retina is getting ground and whitish appearance with very prominent cherry red spots, and look for attenuation of most of the blood vessels with box carrying. If you look for the other eye, we have really nice, very well seen optic nerve. And if you look for this patient, we have temporal areas of drusen in young patient with this. So this could be sometimes a systemic association with central retinal artery occlusion, as we reported in 3 cases before. Another patient with preserved cilioretinal artery that actually keeping the fovea intact, and the vision of the patient were actually preserved in this patient because of cilioretinal. Another patient, even though that having cilioretinal artery intact, but because of that limited area that's supplied by this cilioretinal artery, fovea is involved, so the patient vision is, even though, is affected. Another patient with preserved cilioretinal artery and show that the fovea is intact so that the patient can maintain good visual acuity. Fluorescein angiography usually showing normal choroidal filling, because most of the retinal layers, inner layers, supplied by central retinal artery, while the choroid supplying the outer retinal layers. There is a delay in the retinal arterial and delay in the arteriovenous transit times more than 11 seconds, and arterial narrowing with normal fluorescein transit after reconnaissance. So you might have a patient who had attack of central retinal artery occlusion and coming with recanalizations, and that might show you normal fluorescein angiography with poor visual acuity, so that cannot be correlated. So think about possibility of old arterial or central retinal artery occlusions. This is the patient which show you how much the behavior of the fluorescein angiography in this patient. If you look, we are almost here in the 22 seconds, and we have only couple of telangiectatic blood vessels surrounding the optic nerve, while all the blood vessels are here, doesn't have any blood flow. When you follow it, we have another phenomena. If you look for the blood flow here, we have it airless, then it's getting more and getting back. So with pulsation, this blood vessel is having some flow, getting in and getting less. So this is one of the signs of central retinal artery occlusion, and that's usually, especially in the patient who is having cilioretinal artery occlusion with central retinal vein occlusions. Another patients with retinal vascular occlusion, and I see just only in couple of minutes we have only the cilioretinal artery coming in the times, and then most of the central retinal artery and branches doesn't have any blood flow. With the time we can get it, but actually is less. This is the laminar, and we have the late, we can get the flow, but is less. So this is an important to follow all the sequences and phases of the central retinal artery fluorescein blood flow. OCT, it might shows highly reflective emboli, plaque with the superficial nerve layers. And the ERG in this patient showing diminution of P wave, and that's related to the malar and bipolar cell ischemia with normal A wave in C in these patients. So this is the most landmark of central retinal artery occlusion. We have decrease or diminutions of P waves. Causes, as we mentioned earlier, we have to follow this, but based on your history, you can recognize if the patient having any visible risk factor or systemic disease, so then you can follow. But things in general, if you don't have all of these things in your mind, might be miss one of the major and life-threatening cause of retinal artery occlusions. You have to determine the underlying etiology. That is an important to preventing recurrency of central retinal artery occlusion, and if the patient might develop vital signs like strokes or obstruction of major brain circulations. Causes of central retinal artery occlusion vary depending on the age of the patients, and you have to think about carotid artery atherosclerosis, systemic cardiovascular disease, hematological disease, inflammatory disease, and rare causes. So, if you look for the atherosclerotic changes, we have to think about carotid atherosclerotic disease. We have 3 mechanisms, either thromboemboli or hemodynamic significant carotid artery stenosis and arterial spasms. 45% of cases of central retinal artery occlusion actually secondary to atherosclerotic changes, 60% or greater stenosis in 20% of cases of central retinal artery occlusions, and the leading cause of central artery in patient aged 40 to 6. So when you have a patient in this age, think about the atherosclerotic diseases. And central retinal artery occlusion and high-grade carotid disease lead to 3 of 7 patients have subsequent stroke over 4 years of follow-up. So this is really associated with life-threatening situations. Don't take it lightly. Systemic cardiovascular disease, we have some sort of the analyzing the comorbid disease in these cases, and we found that the systemic hypertension in 2/3 of the patient, diabetes, cardiac valvular disease in 1/4, and cardiac anomalies like patent foramen ovale, and other like hyperlipidemia, carotid artery obstruction, and even though smoking that could be associated. Emboli associated with poor visual acuity and higher morbidity and mortality. Emboli from the heart are the most common causes of central retinal artery in patients younger than 40 years, and amaurosis fugax usually represent emboli causing temporary occlusions of the retinal artery. If you look in general, and we're looking for the prevalence and significance of asymptomatic retinal arterial emboli, we have 1.3 to 1.4 of the population might have visible emboli, and 3.1% in patients over 75 of the age. If they look for the associated risk factors, we have male are more prone, increased age of the patient, systemic hypertension, cigarette smoking, history of vascular disease or surgery, and the people with retinal emboli, they are at risk of 3 times to experience fatal stroke than those without emboli. So, presence of emboli usually it's leading to increased risk of fatal stroke. And the low survivorship in 56% of mortality rate over 9 years when you compare it with 27% in the age matching group. And if you look for the life expectancy in the central retinal artery occlusion is almost 5.5 years compared to 15 years of age matching population. So really this is lead to comparison of this is one of the vital causes of the life-threatening situations. Hematological disease usually common in patients younger than 30, and among them we have the coagulopathies, sickle cell, and hypercoagulopathies usually in the hereditary causes of hypercoagulations like factor 5 leading mutation, protein S deficiency, and protein C deficiency, and antiphospholipid antibodies. Inflammatory, we have giant cell arteritis, we have Sosak syndrome, we have lupus erythematosus, we have polyarteritis nodosa, we have Wegener's and Behçet disease to be considered in this type of patients. Rare causes include Behçet, as we mentioned, syphilis, migraine, which is usually should be considered when you have arterial spasm, increased intraocular pressure, as we mentioned previously, prolonged direct pressure to the globe in unconscious patients, inadvertent intraocular injections of gentamicin, arteritic ischemic optic neuropathy, and Tay-Sachs disease or other storages could be as a risk factor for arterial. So based on the suggestive medical history, direct thyroid diagnostic workup to the most likely cause. The workup, usually we have to have physical examination with complete cardiovascular assessment, including ECG and lab test, as you see here, CBC, ESR, and Doppler color imaging of the carotid, and transthoracic echocardiography will be good for such patient presented with the central retinal artery occlusion. In younger patients, we have to consider anti-cardiolipin antibodies, ANA and double-strand ANA antibodies, and we have to have routine coagulation tests like prothrombin and partial thromboplastin time. Sometimes we need to have specialized factors and platelet activities studies like level of protein S and protein C and antithrombin 3 and others related coagulation factors. Carotid ultrasound imaging to evaluate the atherosclerosis and actually appears to be more sensitive than carotid Dopplers, and even though magnetic resonance angiogram is more superior to both of the carotid ultrasound imaging and carotid Dopplers in cases with highly suspicious of carotid stenosis. Differential diagnosis, we have an ocular ischemic syndromes, partial retinopathy, severe commercial retina, and inflammatory or infectious retinitis. So this is the most common differential diagnosis when you see a patient with central retinal artery. Treatment is usually considered to be true emergency in this patient, and the golden time 90 minutes, and attempting treatment during the first 24 hours after the acute visual loss. The therapy is directed towards three simple and basic things: to lower the intraocular pressure, to increase retinal perfusion, and to increase oxygen delivery to the hypoxic area. So each one of this is having its own maneuver and to follow. Conservative treatment, arterial vasodilations, reduction of intraocular pressures, and that improving perfusions, antiplatelet therapy, reduction of red blood cells rigidity, and hyperbaric oxygenations. Invasive treatment including YAG, laser arteriotomy, and embolectomy, which is usually this is specific treatment and need an expert in that. Local intraarterial thrombolysis, and this is need really a good team that could deliver these types of treatment. So the options available in treatment of central retinal artery occlusion, we have the group of medication like the vasodilators, bentoxin, Vilene, inhalation of carbogene, hyperbaric oxygen, and sublingual isosorbide in suspected patient. And this is lead to increase the blood oxygenations. Ocular massage, as we mentioned, can be done through anti-glaucoma medication or doing paracentesis in this patient, and this is lead to reduce intraocular and increase the retinal artery perfusion, or helping that dislodge of the emboli. Intravenous methylprednisone that might helping in reduction of retinal edema, and as we mentioned that YAG laser embolectomy lead to lysis of the emboli, and intra-arterial or intravenous thrombolysis can lead to lysis of that emboli. The intra-arterial fibrinolysis, it is an controversial issue and limited evidence of improved visual acuity in this patient with urokinase, and the success has been observed with few cases of intra-arterial tissue plasminogen activator treatment, and systemic complication include transient ischemic attack, stroke, and hematoma. So this is one of the treatment. It could be helped, but it's need really people that experience with this medication and under supervision of hematologists and internists in general. Carbogene therapy of 5% CO2 and 95% of oxygen dilate retinal arteries through the CO2 and increase oxygen delivery by applying oxygens to the ischemic tissue, and perform 10 minutes every 2 hours for 48 hours. Hyperbaric oxygen, this is one of the options, but this is time limited and need to be applied in the first 12 hours of the attack of central retinal artery occlusions. And 40% improvement of 2 or more levels of visual acuity. If you are in an area like Riyadh, or you have to know where that available so that immediately you can refer your patient if you are attempting to do this type of therapy. In King Khalid here, we don't have this facility, but in military hospital, it's available and can be arranged to help your patient. Follow-up of this patient need to repeated examination if 1 to 4 weeks, and checking for neovascularization of the disc or iris. So the main follow-up of this patient, besides decreased visual acuity, we have to look for the complication possibilities of central retinal artery occlusion. We have neovascularization of the iris in 18% of an average, and that might lead to neovascular glaucoma, and this is need to be treated by band-retinal. Neovascularization of the disc in 2 to 3% when you compare it with the central retinal vein occlusion, and might end it by vitreous hemorrhage, and treatment with band-retinal fasciculation is the main therapy. If you look for the prognosis and visual acuity, it depends on the presentation and the treatment rapidity that could predict the visual acuity. 21% might have visual improvement of 6 gradient of visual acuity. 35% might having visual improvement of 3 gradient. 25% no visual improvement. And 5.4 of 4 eyes out of 74 of central retinal recover visual acuity better than counting finger. So it is the chance to recover the vision in this patient usually is not that obvious as expected. 10% that they could retain central vision due to the presence of cilioretinal artery occlusion, and they can get visual acuity of 20/50 or better, and 80% over 2 weeks period of these patients. So presence of cilioretinal artery occlusion, it might be the good things for this patient to have their own recover their vision. If you look for the retinal emboli, we have low survivorship, 56% mortality rate over 9 years as we compare it to 27% of the age matching group. So it is really an index factor for the low survivor. And life expectancy in this patient with central retinal artery occlusion, they have 5.5 years when you compare it with the age matched group, which is 15.4. So really this patient at risk of low expectancy of life. Branch retinal artery occlusion, almost the same, but this is mostly involving part of the retinal arterial tree, and usually having an emboli typically originate within the vessels upstreams where they dislodge and travel within the circulatory systems to become lodged downstream in the vessels with the smaller lumen. The most common include cholesterol emboli from the aortocarotid atheromatous plaque, platelet fibrin emboli, and calcific emboli from the cardiac valvular disease. Other emboli might include endogenous emboli and exogenous emboli. Sometimes we have non-embolic causes, and we have to consider it in the patient where there is no risk for the flowing emboli. Almost the pathophysiology same as we have that in the central retinal artery occlusion, and usually we have the bifurcation size are associated with narrowing of the blood vessels. So the emboli could be lodged there. It represents 38 of acute retinal artery occlusion in general. Usually in the 7th decade of life, and usually if it's coming in young, usually rare, in less than 1 in 50,000 outpatients visits. Symptoms usually acute, unilateral, painless, with partial visual loss, and might be recognized by visual field defects. Patient also may be asymptomatic when it's actually not affecting the posterior pole, and patient may give history of temporary episode of visual loss as transient ischemic attacks. Medical problems related to the increased risk of emboli formation like endocarditis, carotid stenosis, coagulopathies, and arterial fibrillation are important to be looked for this patient. The risk factors include smoking, hypertension, hypercholesterolemia, diabetes, carotid artery disease, history of strokes, and transient ischemic attacks. 75% of patients have hypertension or carotid occlusive disease. Ocular examination almost the same as central, but this is mostly sectorial and localized to the affected branch of branch arteries. Cholesterol emboli, also known as Herrnhorst plaques, appear as reducent in yellow platelet, and usually these yellow platelets are white rhomboid crystal measuring 10 to 150 micromillimeter in diameter and less than 3 millimeter, as we see in these patients. They appear yellow in fundoscopy examinations because the blood can be followed beside it. Digital pressure on the eye can make them turn within the vessels, causing them to become more or less visible. Cholesterol emboli in the other side usually do not cause occlusion of the artery by themselves because blood can follow around them, as we mentioned earlier. Their sources are most likely atheromatous plaques in the arteriocarotid system, and their presence even in asymptomatic patients. Platelet fibrin emboli appear as whitish, as we see here in these patients. Gray blood that are mobile, and they may appear as shower and may pass through without causing occlusions, usually associated with carotid or carotid thrombosis. Another type of emboli, calcific emboli, appear as yellow, white, large, black, as you see in this patient, and more likely found in the larger arteries near the optic disc. They are associated with calcific cardiac valve and atheromatous plaque of the carotid artery. In the fluorescein angiography, usually we have an area of hypofluorescence corresponding to the obstruction itself, and with the time might have some sort of hyperfluorescence at the edge of the obstructions. This is the sequences of the patients that having branched retinal artery occlusion, and as you see this area, still we don't have any blood flow, and there is a delay in 50 seconds, in 5 seconds, and in 20 seconds still not appear, and 39, and then in 50 seconds we have starting to have the area of hypofluorescence that's surrounding by low grade of hyperfluorescence. In the ERG, we might be having normal as the affected retina, the mass of the retina is very small, and it may show loss of acetylate potential and transit decrease in the B wave. The emboli disease most commonly, etiology of branch retinal artery occlusion. This is when you compare it with the central retinal artery occlusion. And in the study of 70 patients with retinal emboli, we have 40 cholesterol, we have 8 platelet fibrin emboli, and 6 calcific emboli, and 1 possible myxomatous emboli. Other possible indigenous, we have leukoemboli, we have fat emboli, we have amniotic fluid emboli in cases of pregnancy, tumors, we have talc emboli and corticosteroid emboli when injecting intralesional steroid. We have as well air emboli following trauma or surgery, and synthetic material that used in the cardiac surgery or vascular surgery. It might be source of the emboli. Non-embolic include thrombosis associated with atherosclerosis and described to chemotherapeutic agents. As we see, we have vasculitis like SLE and giant cell arteritis. We have posterior inflammatory condition like toxoplasma. Bahja disease might be associated with vascular occlusions, branch retinal artery occlusion, vasospasm, and examples for that we have migraine. And then coagulopathies in general like sickle cell disease, pregnancy, platelet, clotting factors are considered to be major causes, and compression like periarterial loops, vitrectomy surgery, and trauma, it could be considered causes of branch retinal artery occlusion. Certain cases that we don't have systemic association, we call it idiopathic, and representing a syndrome of recurrent episode of multiple branch retinal artery occlusion in otherwise healthy peoples. And example of that, Sosak syndrome, which is representing microangiopathy of brains, retina, and cochlea, and has been seen in some of these patients. So this is one of the infertility. So in younger patients, more obscure and diverse etiology are likely, and we need to look for that and to know the varieties of possible causes of these patients. We have to look for, in younger patients, less than 30 years with retinal arterial obstruction, migraines. We have to look for coagulopathy abnormalities, trauma, increased intraocular pressures, optic nerve drusen, and oral contraceptives. Atheromatous disease is rare in this age group and merit a more comprehensive review over this patient. So when you have young patient, don't take it simply, and you have to work him thoroughly to look for the possible cause. Routine carotid angiography is not recommended in this young patient. Most of them, they don't have carotid obstruction, and visual prognosis is similar to older patient when you have branch retinal. The workup and investigation, mostly already we say it in the central retinal artery occlusion, so almost similar. We don't have to make the thing. And this is including, as we say, a lot of investigations. Carotid, as we said, is not an important in this patient, and the treatment is not important as you compare it with the central retinal artery occlusion, but investigation of patient usually need to be focused on. And consider the increased rate of mortality. Patient with branch retinal arterial occlusion should receive a full medical workup with special attention to the cerebrovascular and cardiovascular system. Depending on the finding, carotid endoatherectomy or anticoagulation may be indicated. The follow-ups usually, it's not that as frequent as we have the patient with the central retinal artery occlusion. Complication actually in this patient is less. Prognosis is depending in the area that's supplied by the branch retinal artery, and most of the patients, they have good visual prognosis in form 20/40 or better. As we mentioned that early, we don't need to go for that. Another types of obstruction is cilioretinal artery obstructions, and as we mentioned early, that can be seen clinically in about 20% of eyes and visible in approximately 32% of eyes by fluorescein angiography. And in a normal fluorescein angiography, they appear before the retinal arterial circulations and represent 5% of acute retinal arterial occlusions. We have three types of cilioretinal artery occlusion. We have isolated types. We have cilioretinal artery occlusion associated with central retinal vein occlusion, or cilioretinal artery occlusion associated with ischemic optic neuropathy. So, in isolated cilioretinal artery occlusion, usually affects young patient with systemic vasculitis and usually has good visual prognosis. 90% of affected eyes improve to 20/40 or better, vision with 60% returning to 20/20, and account for more than 40% of eyes that affected with cilioretinal artery occlusion. The cilioretinal artery occlusion associated with central retinal vein occlusion account for more than 40% of the cases of cilioretinal artery occlusion, and it is non-ischemic type, and approximately 70% of eyes achieve 20/40 or better visions, and 5% of patients with central retinal vein occlusion also have cilioretinal artery occlusion. Clinically, almost you show the area of ground glass appearance to distribution of cilioretinal artery. And if it's associated with central retinal vein occlusion, you might have the tortuosity of blood vessels that are indicating combined central retinal vein occlusion with cilioretinal artery occlusions. And the mechanism of that, because of the difference in the intraocular pressure and arterial blood pressure, with hydrostatic pressure that driving the blood to this area. So it is a form of stasis rather than to be real obstructions. This is a patient with combined types, and if you look for the sequences, then you can find that the cilioretinal artery occlusion here is being less flow of blood at that area that's supplied by the cilioretinal artery occlusion. As I mentioned earlier, you can see the blood flow in this area, and this is really one of the pathognomonic for the cilioretinal artery occlusions. If cilioretinal artery occlusion associated with ischemic optic neuropathy, usually the prognosis is poor, and usually may be associated with pale disc or hyperemic disc in associations, and might having an acute pale swelling of the optic disc is suggestive of the giant cell arteritis in these cases, and comprise approximately of 15% of all cases of cilioretinal artery occlusions. Usually, we need to have systemic workup. It's similar to central retinal artery occlusion. and an extensive workup for the emboli sources is probably not indicated in these cases, and the work mostly focus on the central retinal vein occlusion, possible etiology. Ocular treatment is generally not given for isolated cilioretinal artery occlusion or that one associated with CRVO. For cases associated with the ischemic optic neuropathy, the most important to rule out the possibility of giant cell arteritis. We have another cause, might be covered quickly, the ophthalmic artery occlusion characterized by no light perceptions. We have shaded spot is not there when you compare it with the central retinal artery occlusion, and more severe retinal whitening. Systemic association is similar to central retinal artery occlusion, but much higher incidence of giant cell arteries in this patient. Another form of ocular retinal arterial occlusion is the ocular ischemic syndrome, and usually having an internal carotid artery atheromatous ulcerations and stenosis at bifurcations of common carotid artery. 5% of internal carotid artery stenosis patients develop ocular ischemic syndrome, and occurs only if stenosis more than 90% of the lumen of the internal carotid that obstructed. Males, females ratio 2:1, and occurs in 50 to 80 ages, most commonly in 60s, and occurs bilaterally in 20% of the cases. We have to follow the rule of 70-70. 70% of blood flow to brain is through internal carotid artery, and you don't start to get trouble until they have at least 70% of occlusions. So 70 and 70 is an important in this patient to look for the age of the patient and the percentage of the obstructions. With 90% of stenosis, 50 perfusion drop within down central retinal artery. And the etiology of finding related to the low arterial pressure and flow of the blood. Usually they have chronic symptoms, diminished visions in the bright light, occur and periocular pains, progressive vision loss, and may have choroidal insufficiency compromising photoreceptors metabolism. Examinations and showed that posterior segment clinical finding include dilated but not tortuous retinal veins, and usually they have dot and blot hemorrhages that mostly at anterior to the equators, and the pressures usually when you press over the globe, you might at this patient you can see the pulsation without even the pressure over the globe, and this is one of the really helpful signs to recognize the possibility of ocular ischemic syndrome. Posterior segment finding include micronees, macular edema in 40% of patient, cotton wall spot, possible cherry red spots due to retinal hypoperfusion, and disc edema generally not found in these patients. Usually the IOP exceeds pressure within central retinal artery and can occur if the IOP is extremely elevated. It appears similar to mild central retinal vein or diabetic retinopathy, and 1/3 of cases have neovascularizations at the disc and elsewhere, and that might lead to vitreous hemorrhage and traction retinal detachment. 50% of cases with MVI, as you see in this patient, developed neovascular glaucoma, and 90% of cases of ocular ischemic syndrome who developed rubiosis iridis have counting for vision within 1 year. If you look for the anterior segment, we have changes because of the decreased pressure, and secondary to neovascular glaucoma, we have KB and corneal striae. This patient, they are having unilateral cataract, and this patient might having anterior chamber reaction in 20% of the patient, and we have to recognize and differentiate between real uveitis and ocular ischemic syndromes anterior chamber reactions. Almost we have red eye because of the shunting. MVI might be seen in around 70% of the patient with ocular ischemic syndromes, and progress to neovascular glaucoma in 50% of the patient. Fluorescein angiography, it might just only delayed choroidal filling in 60%. This is when you compare it with the central retinal artery occlusions. And usually they have patchy choroidal filling, specifically in thin giant cell arteritis. We have late staining of the blood vessels and the choroids. And the microorganism, as we mentioned earlier, the optic discs show hyperfluorescent in these cases. Diagnosis usually clinically and might be by the ophthalmodynometry that could help in these cases. Non-invasive carotid studies in 88% accuracy in detecting more than 50% of stenosis. And no B wave or A wave on the ERG, and color Doppler is the main one to go. In differentiating ocular ischemic syndromes and central retinal vein occlusion, veins are dilated and tortuous in central retinal vein occlusion, while the veins are dilated but not tortuous in ocular ischemic syndrome. Hemorrhages are patchy and mid-peripheral distribution in ocular ischemic syndrome, and hemorrhages are closer to posterior pole and more confluent in central retinal vein occlusions. In differentiating as well, diabetic retinopathy is symmetrical. Ocular ischemic syndrome is typically unilateral and therefore gives asymmetric retinopathy. Whenever encountering asymmetric retinopathy, think about thin vein occlusion and ocular ischemic syndrome. Because sake of times, I have to move faster. Facts for about ocular ischemic syndrome: vision loss can occur in delay to weeks. 90% have vision loss, and 40% of cases are painful due to neovascular glaucoma and dural ischemia or ocular angioma. So, facts about ocular ischemic: high systemic morbidity. We have the 5 years mortality in 40% of the patient, arterial hypertension in 73% of the patient, diabetes in 56% of the patient, ischemic heart disease in 50% of the patient, stroke in 25% of the patient, and peripheral vascular disease in 20% of the patient. So it's really one of the things that you have to think. And if you look for the dynamically significant carotid artery stenosis, prevalence in patients with acute retinal artery, usually in 19% of the patient, and visible emboli alone did not significantly predict the presence of high dynamically significant carotid stenosis. And in all patients with branch and central retinal artery occlusions, we have to have carotid papillary. Medical evaluation is an important, as we mentioned, for central retinal artery occlusions and others, and to look for carotid Dopplers or carotid angiography, or if in MRI angio, is an important in this patient. If you look for the treatment and management, the endoarterectomy or carotid roto-rotring, if less than 90% of stenosis, 1/3 improve, 1/3 stable, and 1/3 is worsens. Aspirin could be with warfarin or Byzantine. Blood thinners could be indicated in this patient. This is just only a review, because I know this is subspecialty lectures, and we are give you a lot of details and important, because this is give you an overview what you have counter in your practice and might be during your theoretical exam. So you need to know about this at least once in your life when you're having this review. Thank you, and if you have any questions, we have 2 to 3 minutes before the grand round. Questions, please. So that's mean either it's not too much or you don't have. Yes, please. Right. Usually this is medium size and distributed eventually. So usually is not localized in the inferior cornea, or might be like the fox. So it is little bit medium. But the most important here, when you are looking for this eye, usually they have hypotony. Look for the microaneurysm is an important signs to recognize with these patients. When you have an obvious rubiosis, this is an important. Patient with uveitis, usually they having prominent iris blood vessels, while in the ocular ischemic syndrome, they have real NVI. Oh, good. Okay, thank you. So that you can take rest while we are preparing for the next grand round.
كيف الميتنج؟
والله بشرك يعني
كيف حالك أسعد
ناس ناس الحمد لله بدأت الدي حضروا مين معالي الدكتور رئيس شو اسمه وزير الحصانة.
ايه اكسل
الحمد لله. This is the first subspecialty. جنبه مسلم. It's the first time to have subspecialty على فكرة. الفاتس خلاص واقفين بس في شيء أبروك الأمير.
That's good.
You are in the board.
أنا your advisor.
طبعا نحن يعني this is what our أنا والله ما صليت عاوز أصلي.
ايه تفضل. بتغير السيت اب. This one.
Can I do it, sir?
The second one, KKESH.
Sure.
Okay, excellent.
Can I do it, sir?
Thank you.
جيب لكم ورقة.
في pointer.
هيكون في اليمين يسار. تفضل يا باشا. فوق شوية. الليزر.
Thank you.
بالتوفيق. They are busy with إذا ممكن دكتور أحمد. Okay, Bismillah ar-Rahman ar-Rahim. Good afternoon, ladies and gentlemen. We'd like to welcome all of you in this grand round. Will be presented by Prof. Khalid Tabara, who doesn't need any more introduction. He's known to all of us as a founder of a lot of ophthalmic society bodies, including this hospital and the university department and the program. And he's, mashallah, continue productive in all the levels of education and research and interest in ophthalmology. So our presentation or our grand round will be today about the ocular infection in immunocompromised patient, and this will be presented by Prof. Khalid Tabara. Please, Prof.
Thank you, Dr. Abdullah. I would like to take this opportunity to thank you and the Department of Ophthalmology and each member of the Department of Ophthalmology for their contributions in the field of ophthalmology and specifically in infections of the eye. Wars and natural disasters come and go. Infections are going to be with us forever. Certain infections have been eradicated by vaccinations, but others have been controlled by public health measures. However, the tenacity of bacteria and the viruses and the resilience of the viruses have led to the emergence of new infections and the evolution of old infections. It is therefore our duty as ophthalmologists and medical scientists to dispel the mystery of ocular infections and try to replace speculations with certainty and fiction with facts in an attempt to understand better the infections of the eye. There are pathogens and there are opportunistic organisms. And recent advances in pharmacology and molecular biology have greatly improved our management of patients. But at the same time, there has been a wide increase in the population of the immunocompromised patients. We did not see this 30 years ago, but this is with you, the new generation. We are going to witness more patients who are immunocompromised, and therefore we are going to have new infections of the eye. Infections not only of the lids and cornea, and in our small subspecialties. It's in fact infections of every structure of the eye that may lead not only to loss of vision, but sometimes to loss of life. It is therefore considered that we as ophthalmologists should be able to recognize these infections early and give them the treatment promptly in order to save the vision and save the life. Over the next few minutes, what I would like to do is try to expose some of my lifetime experience in infections of the eye, not in the immunocompetent individual, but in the immunocompromised host. And this is because you are going to face many clinical situations that are challenging and requires early detection and proper treatment. Over the past 25 to 30 years, I take pride in being a member of a team of ophthalmology at King Saud University and here at KKESH, where we published more books on infections of the eye than any other country in the Middle East. In fact, we published 9 books while we were at King Saud University. And these are the last 2 books that we have published. In fact, this one is the last one, as you can see, with Dr. Ahmed Abul Asrar, Dr. Minsuf Khairallah from Tunis. And this book on ocular infection was published in 2016. And if you want a reference for all the antibiotics that are available on the market that you can compound for ocular infections, it's in this book. And there are chapters on antibiotics in ophthalmology and very specific ways of compounding antibiotics for infections of the eye. And this book is quite a reference. This is by Springer Verlag from Germany, the publisher. Infections of the eye, we put the first edition when I was at King Saud University, and then second edition, and this is the second edition with Bob Heinduck of Milwaukee from the United States, and this book was published by Lippincott. We had a book on diagnostic microbiology and cytology of the eye. Again, this is a book that is a reference for many people who work in the lab in the diagnosis of ocular infections. The book on posterior uveitis covered infections of the retina, and this is with Dr. Robert Nussenblatt, late Robert Nussenblatt of the NIH. Infectious disease of the eye with Gil Smolin and Jack Witcher. We published this book with Williams and Wilkins. And these are 3 volumes from the series on international ophthalmology clinics that covers immunology and immunological diseases and infections of the eye. So I can tell you that our group here had an important contributions to infections of the eye, and I take part as being a member of this team. Now, how do we define the immunocompromised host? The immunocompromised host is a patient who cannot respond to infection or to tumor due to an impaired immune system. This can be congenital, acquired, or iatrogenic. There are many causes of impaired immune system. It could be a disease, cancer, diabetes mellitus, or it could be malnutrition, or the use of biologics. As you know, if you give anti-TNF alpha to a patient who has a latent tuberculosis, you can reactivate the tuberculosis. Drugs and hyperalimentations are causes of the impaired immune system. Of course, there are local factors that immunocompromise the surface of the eye, such as dry eyes, trauma, the use of topical steroids. Of course, there are many congenital immunodeficiencies, but these are rare. And organ transplantation. there are many protocols that have been introduced in order to maintain and prevent the rejection of the organ which is transplanted. These protocols contribute to the immunocompromised population. Now, what are the causes of ocular infections in the immunocompromised host? It can be bacteria, fungi, viruses, parasites, or others. As I started by saying that not all organisms are pathogens. They can be opportunistic organisms, and in the immunocompromised host, most of these are opportunistic organisms. Keep in mind that our environment also is full of successful organisms such as fungi that can cause infections of the eye. Now, this patient had a smooth, uneventful LASIK in one of the clinics here in Riyadh, private clinics. And 2 weeks later, he came to me with a history of blurring of vision in the right eye, and you can see there is an infiltrate under the flap. Why is he immunocompromised? Because LASIK is a trauma which disrupts the anatomic barrier and introduces the organism in it. And at the same time, you use topical steroids on top of that, and therefore you further immunocompromise the ocular surface. So we lift the flap, took a specimen, and the organism was Mycobacterium cheiloni. This is an organism which is common, but doesn't cause disease unless there is an immunocompromising factor. And as you can see here, this is the patient at the time of presentation. We recovered the organism, gave him specific antimicrobial agents in the form of amikacin, and we ended up in 20/25 vision. And this is because we made the diagnosis early and gave the treatment promptly. So you don't have to go to penetrating keratoplasty in many of these cases that you can successfully treat with topical antibiotics. This is a patient who had PKP and developed blurring of vision. As you can see here, this is a patient who had the corneal transplant and was on topical steroids, and the patient had dry eyes. So there are three factors that are contributing to immunocompromising the ocular surface. We culture candida from the surface of the eye. In Saudi Arabia, the west coast, Jeddah, and near the Red Sea, you have mostly Fusarium and Candida. You rarely get Aspergillus. Aspergillus is more common in Najd area. And as you know, the spores of Aspergillus can survive very high temperatures. So much so that baked bread, after going to the oven and coming out, if you have it at home and leave it outside the refrigerator for 3 days, you will get the black spots of Aspergillus niger on it. So these spores can survive very high temperatures. And this is why they survive our environment here in Najd, because these spores can survive easily 60 degrees Celsius. So there is a difference in the causation of fungal infections of the ocular surface between different regions in Saudi Arabia. Now, this patient had dry eyes, and a punctal plug was placed. And the patient came to me, and he said, he's a male. I said, I don't put kahal, but there is a dot of kahal on the eye. And I looked at it, it was a black spot in the punctal plug. I took a specimen with a needle, put it on the slide, and it was fungus, and it grew Aspergillus niger. And you can see that here, this is a device which is immunocompromising, and the patient had dry eyes. There are no tears to sterilize the ocular surface, and therefore developed a fungal infection of the device. And therefore one has to be careful, because some of these puncta that have the punctal plugs may have infections, a source of infections for the ocular surface that can be dangerous. Now, the Aspergillus that's in Najd area are of 4 types. Aspergillus fumigatus, which is the commonest, Aspergillus flavus, Aspergillus niger, I mentioned the bread that is here, and Aspergillus teres. And each one of those can cause infections on the ocular surface only if the ocular surface is immunocompromised. This is a patient who lived in Batha, and he had the bread which was dried, and he tried to break the bread to put it in his milk. So while he's breaking the bread, which is hard, a chip came in the eye, and he developed pain and redness of the eye. So the trauma immunocompromised the surface. And we took a specimen from this lesion, and it was Aspergillus. So as I mentioned, the bread may have Aspergillus spores, and you can, if you introduce them with a trauma to the eye, you may have the infection in the eye. This is GMS stain, the Gomori methenamine silver strain it shows the dichotomous branching of the Aspergillus with septate hyphae, typical of Aspergillus. This is, if you take it from the eye, is Aspergillus fumigatus until proven otherwise. Culture grew Aspergillus, and the patient was treated successfully with topical antifungal agents. Now, this is a patient who had a very smooth phaco and successful phaco, but 3 weeks later, he developed pain and redness of the eye, and he has infiltrates. You can see the fluffy borders, the satellite lesions, the plaque, and this was typical of a fungal infections at the limbal wound. So the trauma immunocompromised the surface, and the use of topical steroids further allowed and invited the fungus to grow in the cornea. And this patient was treated successfully with antifungal agents. And this is the culture showing Aspergillus with the conidia from the culture. And these conidia are not in the thousands, they are in the billions around you. And this is why they are disseminated easily. And they are an important cause of asthma in certain seasons. Keep in mind that we see more fungal infections in March and April and October and November than any other month here in Najd. And this is because the optimal moisture, humidity, is around 25 to 30% during these periods. And this is an ideal humidity with the temperature for the sporulation of these conidia. And this is why we get more spores in this time of the year. This is another patient with a fungal infection. Again, it was Aspergillus fumigatus, the most common cause of fungal keratitis in the Najd area in Saudi Arabia. Keep in mind that this is an emergency. For me, it's an emergency as an infectious disease man, and I don't delay it. And I give the treatment before I send the patient. I take scrapings and look at the cytology and make sure that it is, if it's fungi, I have to start treating immediately. And you can see the cytology and see the hyphae very easily. Why is this important? Because these fungi do not grow like strep serpiginous. The strep pneumo, we call it serpiginous ulcers because it grows on the surface like a snake. But these fungi are worse than the snake. They grow perpendicular to the lamella. And if you take a section through a cornea infected with aspergillus, you find the septate hyphae growing not towards the limbus, but towards the anterior chamber. And if you give them time, you will find the plaque that forms on the endothelium full of hyphae. This is why we say in the hypopion of the bacteria, it is sterile. But the hypopion of fungi has hyphae. And you have to be very careful. And sometimes we irrigate the anterior chamber with voriconazole in order to prevent dissemination of the fungus. So fungi are tough to diagnose, difficult to treat. And this is a 16-year-old patient who had coma with ketoacidosis, diabetic ketoacidosis. She had type 1 diabetes mellitus. When we looked carefully at her, we were consulted by the internist because she was admitted to the internal medicine area. We found out that there was a perforation of the heart palate. And she had necrosis and ischemic changes at the lid margin. And she had hypotony of the right eye. This is mucormycosis until proven otherwise. It's also called it's called ororhinocynocerebral mucormycosis. It belongs to the group phycomycetes, which are aseptate hyphae, produce aseptate hyphae, a very dangerous mucormycosis in diabetics. Why is that? Because they live preferentially on acidic pH. And these patients have acidic ketoacidosis. And the pH for mucormycosis, the ideal pH, is 6.6 to 7.3. And they proliferate. And they become angioinvasive. They invade the vessels. Why they invade the vessels? Because there is iron in the vessels, hemoglobin. And it cannot survive except on iron. So it needs an acidic pH, it needs the iron. The acidic pH is from the ketoacidosis of the patient, and it invades the vessel in order to survive. And therefore, it occludes the vessels and causes ischemia. And I have sections, pathology sections, showing that some of these are enmeshed inside the vessels, causing big clots, and therefore causing ischemia of the anterior segment as shown here. And this is a patient which shows the ischemic changes on the lid with necrosis of the lids. And this is the anterior segment with necrosis of the anterior segment. If you leave this, the patient will die. And indeed, the patient died because the mucormycosis reached the brain. You have to treat them aggressively, and sometimes you may have to do exenteration in order to save the life of these individuals. So this is a dangerous disease. Another fungus is an interesting fungus. This is an angiotropic fungus. It loves blood vessels because it has to go after the iron, while others are neurotrophic. And this is a patient, a 7-year-old male that I saw at King Faisal Specialist Hospital. The patient had Hodgkin's lymphoma and had conditioning regimen for hematopoietic stem cell transplantation of cord blood. Patient had prophylaxis for graft versus host disease. So he was on immunosuppression, and therefore he was immunocompromised. He complained of blurring of vision in the right eye. And what we saw was a posterior hypopion. And the patient had evidence of pus behind the vitreous here on the retina. And the optic nerve was involved. In fact, the organism came from the CSF to the optic nerve, to the retina, and to the anterior part, the inner part of the retina, causing the posterior hypopia. The other eye was perfectly normal. And we did MRI. There were multiple less than 1 centimeter lesions with central hypointensity involving the basal ganglia. The left thalamus and the frontal white matter bilaterally had these lesions as well. And this is the MRI, and you can see the coin-like lesions that are here, that are centrally translucent. I asked the radiologist, what could this be? And he said, this is an immunocompromised patient. These are typical of toxoplasma. I told him, but the lesion in the eye did not look to me like toxoplasma. It looks like a more severe either bacterial or fungal. He said, it cannot be bacterial. These are toxoplasma. I told him, okay, since we don't have an agreement about this, I will go and take a specimen from the eye. And he said, okay. So the findings in the brains were consistent with an infectious process in an immunocompromised patient, most likely representing toxoplasmosis. This is the impression of a prominent radiologist. The infectious process involved the right globe and associated proptosis with it. So when I looked at it, there is nothing that suggests toxoplasmosis, and there was no evidence of vasculitis. It was only a papillary infiltrates and growing into the vitreous. Growing into the vitreous suggests that this is not toxo. Toxo is an obligate intracellular parasite that loves the ganglion cells, not the vitreous. And this organism was growing into the vitreous. So I went and took a specimen from the vitreous. And the vitreous aspirate grew Chitomium atrobrunia. Well, last year, the Committee on Nomenclature changed its name Chitomium to Amesia. So now we should call it Amesia atrobrunia. And this is a CNS tropic fungus that loves the CNS, does not like to grow anywhere else. And it came from the central nervous system to the eye via the sheath of the optic nerve. Now, this is an iatrogenic form of an immunocompromised patient. How about other forms? How about solid organ transplantations? And we are doing so many of those. Heart, kidney, lung, liver, and so forth. You cannot have these organs survive unless you immunocompromise the patient. And if you do immunocompromise the patient, then you may have secondary infection. Now, there are protocols for organs transplantations, and many protocols. But you have to maintain a delicate balance between immunosuppression on one side and prevention of rejection on the other side. Keep in mind that ocular infection in immunocompromised patients is difficult to recognize because the symptoms of inflammation are diminished because he is taking immunosuppressive agents. And there are broad opportunistic organisms that you have to identify. So if you have a uveitis in a patient with kidney transplantation, this is until proven otherwise, because these patients are on immunocompromising agents. Now, in ocular infections, in patients who are immunosuppressed, we have to identify the source and cause of the infection. We have to identify the type of immunosuppression. We have to look at the time of onset and prophylaxis. This is very important. Is it an early infection after transplantation, or is it a late after 2 years? 2 years, they are on a maintenance dose, and it is completely different type of organism. While if it is early in the first 2 weeks, they are on the maximum immunosuppressive protocols, and therefore different types of organisms attack the eye. So what are they? The source of infection can be the patient, himself or herself, or it can be the organ that you transplanted, or it could be nosocomial, or it could be community infection. Now, what are the organisms that are introduced from the donor derived? That is, it's coming with the kidney, or with the heart, or with the liver. It could be CMV, and this is why we have to know sometimes before the transplantation whether they are CMV positive or CMV negative. Herpes simplex can be transplanted, herpes zoster, Epstein-Barr virus, toxoplasma, Mycobacterium tuberculosis, and rarely HIV and rabies, but it has been reported. How about the recipient himself, the patient? You can have derived infections like tuberculosis, CMV, herpes simplex zoster, but also human papilloma virus, maybe in the recipient. Rarely it is with the organ transplant, because you are transplanting a kidney, for instance, or a liver. But most of the papilloma viruses are not in the liver, and they are at the mucous membranes. So this is why it's unlikely human papilloma virus comes from the recipient and not from the donor. EB virus and toxoplasma. This is a patient, and I'll give you an example of a papilloma virus. This is a patient who had kidney transplantation in Dammam at the University Hospital. And he developed a lesion after kidney transplantation. In fact, he said after 2 months of kidney transplantation. He went to a doctor, ophthalmologist. He told him, I have to excise it, it's a pterygium. So he did excision. It recurred. He went to another ophthalmologist, and he told him this has to be taken out. So he took the pterygium another time. This is when he came to me here in Riyadh. So I looked at the lesion. It was elevated. It has all the characteristics of a malignancy. So I told him, this is probably a malignancy. I have to take it out, and we have to submit it to pathology. The interesting thing is that he said, no, I want to go and have istikhara, and I'll come back to you. So I saw him in May. He came back in November with this lesion coming like this. So I told him, this is carcinoma until proven otherwise. And you know that many of these conjunctival carcinomas are due to papillomavirus. And therefore, this patient had expression probably of the papillomavirus after the immunosuppression and developed carcinoma of the conjunctiva. We sent it to pathology, and we found evidence of atypia, acanthosis, keratosis, dyskeratosis, and there was dysplasia and metaplasia. All these findings are characteristics and typical of squamous cell carcinoma of the conjunctiva. And these lesions here that you can see typically in these patients are keratin pearls that are quite characteristic of squamous cell carcinoma of the conjunctiva. And this patient, we did excision. We did not admit to hospital. We did the excision. And we did mitomycin C on top of that. And I saw him 5 years later with no evidence of recurrences. Of course, I was fortunate because during those years that after we excised it, the patient had tapering of his immunosuppression as his immunity was built up, and therefore there was no recurrences of the squamous cell carcinoma. Nosocomial infection are bacterial usually, those that are acquired from them. You don't get a herpes virus on a bed for more than few hours. It doesn't say, it has to be intracellular. So these bacteria can stay, and there can be MRSA, can be vancomycin-resistant Staphylococcus aureus, or it can be Clostridium difficile, and sometimes Candida. You can acquire it in the hospitals as well, which is fluconazole resistant, we call it. Now, we mentioned the donor, we mentioned the recipient, we mentioned nosocomial, and the final one is community. After the patient gets discharged, he goes to his community and he might get nocardia, aspergillus, candida strep, and any member of the microbiological zoo that you have around you. Now, what represents a high risk of infection in these patients with kidney transplantation or heart transplantation or what have you? Those who have T lymphocyte depletion are at the highest risk. Pulse corticosteroid therapy, plasmapheresis, patients who have rejection because it invites the physician to give more immunosuppression, latent infection, prolonged intubation, and prolonged use of catheters can increase the risk in these patients. Patients with low risk of infections are those who have immunologic tolerance, who have HLA matching, who have technically successful surgery, whose antiviral prophylaxis is adopted early, and those who had appropriate vaccination. I would like to come to this point at the end just to tell you how we can, as ophthalmologists, can collaborate with our colleagues in internal medicine and other specialties to help them select ways to prevent such infections in the eye. I had the opportunity to see 11 patients at King Faisal Specialist Hospital who had ocular infections, serious ocular. I called it major ocular infection after solid organs infections. I saw 3 cases with herpes, 2 cases with CMV retinitis, 2 cases of toxoplasmic retinochoroiditis, 2 of tuberculosis, 1 of strep pneumonia, and 1 fungal endophthalmitis. This is a 26-year-old, 3 weeks after kidney transplantation. What does this tell you? 3 weeks, it means high immunosuppression, because all these protocols require high immunosuppression initially in these patients so that they will not have early rejection. And the patient developed herpes zoster ophthalmicus. And patient was given antiviral therapy and had complete recovery of his lesions. This is a patient, 45-year-old male. He had cardiomyopathy with heart failure. He had then heart transplantation, developed redness and blurring of the vision. Blurring of vision and redness. He was complaining for 1 month, and nobody in the internal medicine team looked at the eye. Well, his vision was hand motion in the right eye and hand motion in the left eye. This is the right eye, showing complete corneal abscess. Of course, they are very busy by the heart transplant, and the patient, when we cultured him, grew strep pneumo, a simple infection that can be recognized very early. And this is the other eye with strep pneumo. So what did we give him? Topical subconjunctival penicillin G only. We don't have to go to third generations and antibiotics. Penicillin G, it was the best drug. And the patient had complete recovery of his streptococcus pneumonia keratitis and had recovered his vision in both eyes. This eye was 20/100, the other eye was 20/50, and he was happy. This is another patient, 28-year-old male patient. I examined and saw in the eye a toxoplasmic reticulochoroiditic scar, a coin-like lesion with pigmentation. I told the nephrologist who was going to do kidney transplantation, this patient had toxo lesion. Shall I give him prophylactic? He said, no, we don't give prophylaxis for our patients here. I'm fine. And again, 1 month after the kidney transplantation, the patient developed blurring of vision, and he had next to the scar, a localized necrosizing retinitis. Well, these scars are not sterile, and we have to keep this in mind. And I wish I gave him the antibiotic therapy before, but we had to give it later, since the lesion was not very close to the macula, so he regained vision and there was no problem. But these lesions have toxoplasma cysts, and the cyst may have anywhere from 50 organisms to 2,800 organisms. And as it stays in the retina, it grows, it multiplies slowly. They are called bradyzooids, not tachyzooids like the infection when it happens. They are called the bradyzooids because they are slowly metabolizing. And they keep dividing, but slowly. And they increase like by 100 every year. And when it gets stretched, it ruptures. And the toxoplasma gets out of its sac and starts to invade other organisms around it. If the immune mechanisms are depressed, like by stress or by immunocompromising factors such as immunosuppression, then you will have recurrences of the toxoplasmic retinitis next to the scar, because the scar, it will stay viable all your life. And many of us carry toxoplasma in cysts without any symptom. So keep this in mind, that toxoplasmic scars have toxoplasma cysts that can rupture with immunosuppression. And you may have to consider using prophylaxis in some of our patients who have autoimmune disease and require, for instance, anti-TNF alpha or whatever you have. Now we have a new biologics and new drugs for the Janus kinase inhibitors. We call them the Janus kinase inhibitors. There are four enzymes that are Janus kinase. The JAK1, it's called Janus kinase 1, Janus kinase 2, JAK3, and tyrosine kinase 2. A very important breakthrough in 1992. It is one of the most important signaling apparatus of the lymphocytes. It helps the lymphocytes to get rid of toxoplasma, because Th1 helps to eradicate toxoplasma, to kill toxoplasma or any intracellular parasites. And why did they call it Janus? This is after the Roman mythology of the god Janus. The god Janus in Roman mythology is the god of all beginnings and end. And therefore they call it, thus the term January after the god Janus. And the family of Janus kinases, these they engage specific ligands and phosphorylase we call it the STAT, signal transducers and activation of transcription. I'll not go into details, but these STATs have specific effects on the gene that causes transcription in the lymphocyte, causing differentiation, regulation, inflammation, and so forth. So if you inhibit them, you can arrest the lymphocytes. And this lymphocyte inhibits intracellular parasites. So what happens if you inhibit the Janus kinase? You will get recurrences of toxoplasmosis. And in fact, these are important, by the way, drugs that are used. For instance, ruxolitinib is the first agent approved by the FDA in 2011 for myelofibrosis. There was no drug for myelofibrosis until this drug came into the picture. They are used for psoriasis and rheumatoid arthritis. Tofacitinib is used for rheumatoid arthritis, approved in 2012. Erlotinib is used as a tyrosine kinase inhibitor in certain types of cancer of the lungs. So these are important drugs that we have to use sometimes. But you have to know about them, because if you have toxoplasma in the retina, you can have bilateral toxoplasmic retinitis. And this is a report by Rao and associate, development of bilateral acquired toxoplasmic retinochoroiditis during erlotinib therapy. And this was reported in JAMA, actually in 2014. And this is the patient of Rao, showing the right eye and the left eye with bilateral retinitis. And sections of the retina showed evidence of toxoplasma cyst. You can see the toxoplasma cyst on this side here. And this is inside the retina with necrosis of the retina and disruption of the anatomic barriers of the retina. Another report by Goldberg, when you inhibit the kinase, you will end up in bilateral toxoplasmic retinochoroiditis, and this is what happened in this case of Goldberg and associates. And here you have a retinitis and the retinitis here, and this is because of this. So you have to keep in mind, when you have bilateral toxoplasmosis, you have to ask the patient whether he is receiving any of these tablets that are kinase inhibitors. The next is an interesting case, a 59-year-old male who had renal transplantation. He was on prednisone, cyclosporine, mycophenolate mofetil, thyroxine, and omeprazole. Developed redness of the eye, and the patient had not, when we saw him on the floor, the patient was still in the hospital. And we found out light perception in the right eye and 2400 in the left eye. The patient was on topical Pred Forte and cyclogel because of uveitis. Indeed, the patient had uveitis. But I said that if you have immunosuppression and you have uveitis, it is an infection until proven otherwise. Should you give more steroids? You don't have to give more steroids. This is an infection. But you have to determine the cause of the infection, because it can be sight-threatening or life-threatening. So this patient had evidence of a hypopyon, posterior synecdoche, and the patient had uveitis. And this is the other eye. He had the cataract. Of course, he was on systemic steroids, and he developed cataract because of the systemic steroids, posterior subcapsular opacities. But when we looked at the fundus, we found evidence of a focal area of choroiditis in the other eye. And you can see the choroiditis over here. There was a small vessel with vasculitis, and there was an area of choroiditis. And when we requested studies for CT of chest, he had basal nodular infiltrate suggestive of fungal infections. This is what the internist, what the radiologist suggested. Well, he was studied for rejection. It was, and the cyclosporine level was okay, and he had type 2 diabetes mellitus. Vitreous aspirate from the right eye was subjected for PCR, and it came out to be Mycobacterium tuberculosis. After that, we asked for sputum cultures, and 3 sputum cultures for Mycobacterium tuberculosis were all positive. And as you can see, the radiologist made a misdiagnosis of fungal infection. The internist made the diagnosis of uveitis and started on steroid. So these patients who are immunosuppressed should be handled differently. And you should always say infection until proven otherwise. He was given antituberculous therapy. He had complete recovery, but he ended up in normal vision in the eye that had the choroiditis. You can see the area of patched, healed choroiditis. And the other eye that had uveitis went into phthisis bulbi after the treatment. So no light perception in the right eye, 20/20 in the left eye. Another 50-year-old with multifocal choroiditis and evidence of vasculitis in an immunosuppressed individual following liver transplantation and immunosuppression, and the diagnosis was Mycobacterium tuberculosis. This is a patient, 39-year-old, with autoimmune hemolytic anemia that had kidney transplantation on immunosuppression, and this is the fundus picture. And this patient had evidence of CMV retinitis, and the patient had to be given again cyclovir in order to control the infection. The infection is important not because infection of the retina only, but because it can upregulate certain cytokines that can participate in the rejection of the kidney. And therefore, you have to be very careful and give an aggressive antibiotics in these patients. So the CMV retinitis, as I mentioned, it can be the donor, the recipient, or it can be community acquired. Unfortunately, I will not be able to go over the prevention, but I would just conclude by saying that patients who are immunocompromised may have an infection either by a pathogen or by an opportunistic organism. It can happen anytime after the transplantation. But keep in mind that the agents, the viral agents, can occur very early, while bacterial and community infections can occur very late. And this patient had both toxoplasma scar and CMV retinitis, and the patient was immunosuppressed. So keep in mind that early recognition, early diagnosis, and prompt treatment can help in saving the vision of the patient and the life of the individual. Thank you.
Thank you, Prof, for this interesting presentation and inspiring talk, as usual. We'll start now with the discussion. If any questions from the audience.
Thank you, Prof. Tabara. It's really great to touch this subjects of immunocompromised patients, as we have a lot of post-organ transplant now surgery in all offers In the past, we have the patient with HIV and immunocompromised patients, but nowadays, post organ transplant need and attentions, and most of these patients, they are presenting really with atypical presentations. Usually, they don't have the typical signs that we see in our patient with infectious etiology. So really, I would like to thank you. And most of the patients that we have, usually they're having dilemma. Most of the times they don't have clear signs that we can see, except in few patients. I'm talking from the perspective of panuveitis that's presented with the vitreous, obesities that cannot help you to see the real signs of this patient. So we need to use our sense and to get samples for definite diagnosis. So what do you think in this patient when you have dilemma that you cannot get all the signs that you are thinking this is a case of infections in immunocompromised patients?
We have to be more aggressive in patients who have signs and symptoms of inflammation in the eye that cannot be explained, who are immunosuppressed. And we have to be more aggressive, either to get a biopsy or to take a specimen, because sometimes you cannot rely on lab tests, and especially because these patients are immunosuppressed, you cannot rely on antibodies. For instance, it can be false negative. So you have to get biopsy specimens in these patients. Like the case that was diagnosed like toxoplasma, and the patient had fungal infections, he would have died without an early diagnosis. And following treatment, all these coin lesions disappeared and had the appropriate antifungal therapy. So this is a good point, that we have to modify our strategy in diagnosing these patients and not to rely on the classical textbook picture.
I have a question, Prof. If you have a consultation from an internist who will do a transplant, liver or solid organ transplant, and the patient known to be a case of herpetic keratouveitis, we used to do in the one who is having TB or latent TB to couple it with the anti-TB. But how about the viruses, latent viruses? Do we do the same? Should we put them on prophylactic antiviral?
Yes. Yes. I didn't get to the section of management of these cases. First of all, vaccination. Before, let's say somebody, he's going to undergo kidney transplantation after 2 weeks or 4 weeks or whatever. Because these are elective cases and they are not rushed. You cannot give an attenuated live virus, live vaccine, except 4 weeks before transplantation. If you want to give dead or inactivated vaccine, then you can give it 2 weeks before. So this is vaccination before. But if somebody had the virus, then you have to give prophylactic therapy. And there is an approach for some of these patients. We call it preemptive diagnosis. Preemptive diagnosis is you make weekly blood culture or blood samples to find out whether by PCR you can detect CMV. Once you detect it, you start the treatment. You start Valsite or ganciclovir in order to prevent the CMV. The prevention of CMV, not to prevent retinitis, but to prevent the rejection after the CMV sets in. So these are strategies in order to do preemptive therapy for these patients. And you can use, for instance, somebody with toxoplasma, you can with a scar in their fungus, you can advise to give them, for instance, spectrum before and during and after the kidney transplantation until the immunosuppression goes down, and you can stop it.
I have the same comments regarding to the patient who's going for organ transplant or is going for chemotherapy for any types of malignancy. Might they have some sort of latent tuberculosis? And this could be in general. So they are using any prophylactic in their protocol? in this
For
type of
tuberculosis,
for
yes.
latent tuberculosis.
Latent, yes.
Is there any all the medications or just only
No.
single?
No, usually we give two drugs, like
Rifampicin and
Rafina,
INH.
for instance, Rafina. You can give 2 tablets a day and that's it. Rifamycin with isoniazid. Excuse me?
According to the PPD, or you need to or CT scans, or how would you work them?
According to PPD or
Quantiferon.
or quantiferon.
Quantiferon test. It's not just only beta.
Or quantiferon. Some people don't have the quantiferon, so PPD, yes.
Yeah, usually even BBD in our university regimen in the ID, usually they ask us to couple it with INH
Yes.
when
Yes.
medicated for 6 months.
Absolutely.
Yeah.
But even though the BBD is equifocal, quantiferon is more for this patient, usually for organ transplant. They are sensitive with tuberculosis.
You see, PPD in small percentage, they might be due mycobacteria species, not tuberculosis. That's the only thing that about PPD. But in general, if you have a PPD positive, that's it.
Definitely.
Okay. Question, Dr. Muhannad?
Thank you, Prof, for this lecture. My question regarding the patient with the OSSN post-organ transplant and immunosuppressive therapy. Is it always secondary to HPV? If we see OSSN in a patient who is in immunosuppressive therapy, is it always secondary to HPV? And if this is the case, will cidofovir will be the first-line therapy for them?
For papillomavirus, you said?
Yes.
For papillomavirus. The ideal is to take the vaccination, before. This is, but I have not treated patients with, with cidofovir. It's a toxic drug. It's not an easy drug to take. Yeah, but I have not treated papillomaviruses. But it is now, there is a feeling that, the papillomaviruses that are available, vaccination which is available, covered papillomavirus 16 and 18, which are the main cause of cancer of the cervix. But they can also affect other types of papillomaviruses. They cross-react.
Okay. By this, I'd like to thank you, Prof, and thank all the audience for their attendance and this.
Thank you. Thank you. Thank you for coming. Yes. Voriconazole 1 milligram. You can. Yeah. If you can take specimen also. If you find evidence of hyphae, you have to give it.
Well, as you said, it's well documented that the hypopion with the fungal there is and with the view with the broad penetration of the fungal medication, it might rationale the injection intracameral. I review a paper, the review of Inflammation Immunology Journal. There was one of the papers was sent.
أهلا كيفك؟ كيف أحوالك؟ الله يسلمك. Good to see you. الحمد لله. الله يخليك. حافظك. الله يسلمك. يعطيك العافية. يعطيك العافية. يا هلا الحمد لله. الله يسلمك.
So there was a good series of cases in which when they inject intracameral, they end up with endophthalmitis. There is a good number of cases they end up with endophthalmitis.
Yeah.
So the conclusion was not to go for intracameral unless the case was not under well control of the topical.
Yeah.
So this is the it was only one paper.
Diluted, it's a safe approach with voriconazole.
Sometimes you can introduce it more, introduce more action.
You will have to go and there is infection everywhere, so you have to approach it. But Intracamera, I have done it at least 3 times, and it worked.
We usually
I give it also before I give it before I do PKP in cases where we are doing PKP.
yeah, that's fine.
Yeah,
We already opened the eyes.
Yeah,
The eyes open
yeah.
already. We give intracameral washing.
Yes.
But I mean, we can give it intrastromal, we can give it in the topical, and
Yeah.
if there is no response, then we can enter in the eye.
Yeah, yeah. But, yeah, you know, this you'll have to weigh the risks and benefits of all these procedures. Yeah, Allah Habib. This, Allah يسلمك. Alhamdulillah, Allah يسلمك يا Nabi. عليكم السلام. اهلا فيك يا اهلا بيك الله يسلمك. اهلين يعطيك العافيه. Do you know how to eject it? This is a different type. How do you do the ejection? هذا الإكسار هيدا how do you ejection بدنا نسأل أنا إذا طالع قولي له بليز يجي لا projectionist.
Hello.
Hi.
I'm Andrea Gomez from Brazil.
Yeah, nice to meet you.
I just came to tell you that I really loved your lecture.
Well, thank you. It's good to hear that.
I know your background, the beginning of this hospital.
Yeah.
And,
You're
I
São
came
Paulo?
just to see you from São Paulo. I am here with my husband. And, yesterday we saw that you were giving this lecture, and I really enjoyed it tonight.
Thank you.
Thank you for that.
Good to see you. Bye-bye. How do you eject it? How do you
Eject your,
this is the one.
you want to eject this?
Eject it.
This one, doctor?
Okay. That's it?
Yes, doctor.
Thank you. Allah Hafiz.
It's good. Speaker on. Yeah, it's good now. You know, Ali, sometimes you can, no, it should be like this. Yeah, that's good. Very well.
Because otherwise, when there is no light, sometimes they use this as a microphone. It happens to me, boss. So I have to open this.
Yeah, but
It's not there, boss.
keep it like this. Okay, that's good.
It happened twice actually.